We're here at the Australian New Zealand Society of Nuclear Medicine meeting at the Melbourne Zoo, so you can probably hear animals in the background. And we've got another episode of Professor Prof Baum from Bad Berka in Germany, who's talking about theranostics and about some of the new things that have happened. And I think it's turning a lot of what we've done in medicine and nuclear medicine and head on its head in many ways. And so to have him here to talk for a few minutes. So we can start, perhaps tell us a bit about what your centre does at Bad Berka, just very briefly.
Very briefly, Bad Berka is a small city of just 8,000 people living there. So it's more a village than a city. And it's located between Frankfurt and Berlin. And I started to build up a PET-CT center and nuclear medicine department there about 15 years ago. And our idea was to use molecular imaging with PET-CT for diagnosing disease, and later on to use specific targeting molecules, peptides or antibodies, also labeled with radionuclides to treat disease. So theranostics mean to combine diagnostics, a specific agent which is used to diagnose cancer, and later on to use the same vehicle labeled with a therapeutic radionuclide, a beta emitter, for example, or alpha emitter to treat the disease.
Right, and obviously the key thing about that at the moment, the one that's really achieving a lot of success, is the somatostatin type treatments. And we've talked about this before on the podcast. We've actually interviewed Dick Queckerboom about some of his work on this.
Yeah.
So it's something that'd be familiar to some of our listeners. But what you've done, you've taken that a little bit further. You've really gone into, rather than just blanket treatments, you've gone into individualised treatment and looking at how each treatment, how we should target each patient individually. Perhaps we could start by you talking about the imaging, how that's changed from indium to gallium-68, perhaps.
Yeah. I know Dick Queckerboom very well, and his group, they were essentially very important to introduce this concept of somatostatin receptor imaging. Actually, it was Eric Krenning who introduced that with an indium-labeled compound, and later on to use lutetium-labeled peptides for treatment of neuroendocrine tumors. I think our part was to look into the specific uptake into this tumor and to quantitate this using PET-CT. Because when you are using OptioScan, you are just looking at images, and there is a so-called Krenning scale, which says more than the liver, equal to the liver, or less to the liver, or no uptake. But that's all. But indeed, when we looked at the series of more than 1,000 patients we studied with gallium-68 labeled somatostatin analogs and PET-CT, we were seeing that the uptake is dramatically different from, let's say, an uptake of 2.3 SUV max to 152 SUV max. So to have a visual score is not enough to really use this score for predicting therapy results. So what we are doing is that we are using PET-CT to quantitate the uptake in the tumor, and based on that to individually calculate the therapeutic dose for the patients, and to say, okay, these patients need not 7 gigabecquerel, but needs probably 5.5 gigabecquerel or something different in between. So coming away from the strategy that nuclear medicine used for more than 60 years in thyroid cancer, giving fixed doses to patients, let's say 100, 200, 300 millicurie, we are thinking that in the future, with the possibility of having molecular imaging as a quantitative tool to predict the uptake in the tumor, we can do what the external beam radiotherapists are doing since decades, namely to look at a specific individualized tumor dose. Okay, and I think this is probably a major advantage, because you can save normal tissue, especially the kidney from toxicity, and you can increase, on the other hand, the efficacy of your treatment by giving higher doses to tumor if it is needed.
Right, but also it's not only about the uptake, but it's also the distribution and the characterization. For example, you showed the flip-flop phenomenon between FDG and gallium-68, so that you could see some patients had very high FDG uptake, they often had low gallium-68, and vice versa. So you could look at the characteristics that whether they'd be better treated with a combination of therapy or not even treated with the lutetium or the yttrium therapy at all.
That's what we call the BBS, the Bad Burka score.
Yes.
So it's a real score of about 9 or 10 parameters, which together give us a complete image. What is the real biology of the tumor? What is the aggressiveness of the tumor? What is the tumor volume? What is the expression of somatostatin receptors? And all this together will enable us to make a real personalized nuclear medicine therapy. That means to look at the individual patient and to determine what is the real activity they need, how often will they need that, and so on. So we are just at the beginning of this. I mean, up to now it's more or less a concept, okay? But as we gather more data, and we have done more than 3,500 therapy cycles now, and we have all this data in a database, so we can look on a long-term perspective, what will be the outcome? Did we make it correctly? And in future we can look prospectively, if we change this parameter or this parameter, we are using this peptide or we are using this therapy activity for treatment, where we are doing better and what is needed to do the best for the patient.
Right, well, I think that's an important point. A lot of the patients you showed had dramatic improvements and had very advanced disease. What's more, the existing treatments using pharmacological antibodies were very, very expensive. This was a much cheaper approach. So not only are you saving money, but you're actually saving lives, and which all at once. So by tailoring that in specific, in terms of looking at those details, you can really improve the outcome for patients and improve the outcome for governments or insurance companies who are paying for these things.
Yeah, I think what is really very important today is the quality of life a patient has under his treatment. And chemotherapy works, but it destroys also a lot of normal cells and causes a lot of adverse effects to the patient. And this new molecular targeted therapy, which are, by the way, not really new. If you look at the first therapy ever, which was performed in nuclear medicine, was iodine-131 therapy. And iodine-131 by itself is a serognostic radioisotope because it can be used for diagnosis and for therapy of cancer. So the concept is not really new, but having PET-CT available, and nowadays we did not discuss it, but it's also coming, what is quantitative immunohistochemistry. So we can also look at the tissue of the patient by molecular pathology and quantitate the uptake in the tissue of the patient itself, and translate that to PET imaging and translate that to therapeutic results. Okay?
But you can also go back and use the imaging to pick the right place to biopsy, so you don't end up with biopsy areas. So they all fit in with each other. Biopsy area, we saw some patients in the following talk that had one tumour which was FDG positive but gallium-68 negative, but another part of the same patient had the flip-flop phenomenon. So by knowing where to put your needle, we can help that way.
Absolutely. We call this PET-CT guided biopsy.
Yes.
And we are doing this now routinely, actually, in our center, that the radiologist who is doing the biopsy or the gastroenterologist doing the biopsy with ultrasound guided, they are using the PET-CT image and say, okay, this is a part of the tumor we are really interested in. Mostly it's FDG positive tumor because these are the more aggressive cells, and these are really determining the long-term prognosis of the patient.
And if they're in the liver, you might want to do therapy if it's in the right place and those sort of things. So you're targeting that individually. This requires not a blanket approach, it requires training. And it requires a lot of expertise, and it requires doctors, technologists, chemists, all these people to be trained properly. So that brings me back to one thing I was going to mention. there are some conferences coming up that I think may be interesting to people because they really need to attend these things to learn their training. The Chandigarh's coming up in India. There's the warm people. There's lots of people who are doing these type of therapeutic approaches. Perhaps you might suggest where people can get information on this type of approach.
Yeah, actually, I can suggest we are founding or creating now what we call the TRC, Theranostics Research Center, which will be a training center for people who are interested in this approach, and not only for nuclear medicine physicians, but also for technologists, for radiopharmacists, for radiochemists, for physicists who are doing the dosimetry. And you are completely right, it needs a team of people to be successful and to achieve this goal, and it needs constantly training on these issues. And in Bad Berka we will create a training center and probably spread it out on a wider basis by WARMS, by the World Association of Radiopharmaceutical and Molecular Therapy. And I will be president of WARMS in December this year. And one of the real topics and interests I have for my time of presidency is to really provide people with more information and more learning on this molecular imaging and therapy.
Well, again, that's absolutely important, particularly if you understand all those things, even in terms of just the technologist reconstruction. If you know the range of your therapy, the distance it's got to travel, you know what resolution you need to reconstruct it, or how to reconstruct it and produce the right region of interest to measure uptake. All of those kind of details are important after.
Absolutely, absolutely.
Yeah, that's very exciting. Well, thank you very much for giving up your time. I know you're very busy and you've just come straight here from Germany. Thank you again.
Thank you for your interest.
It's a pleasure.
Okay.
Thanks.
Bye.
Bye.